The focus of this panel is going to be on who to test and when to test. And this is a difficult problem. I wish we had guidelines that would tell you exactly what to do. The state medical boards have recommendations that you test your patients' urines when they're on chronic opioid therapy, but it doesn't tell you, do you do it the first time, you do it every time? And you can understand why this group here, when they get a referral from us in primary care, they would do it at the first visit. That's their recommendation. First time you see a patient, you should do a urine drug test. In reality, in our setting, patients come in, they have acute problems, the problem resolves. They may be on an opioid, you may not put them on an opioid agreement, you may not do a urine drug test because it's a short-term problem. But the question is, there's some point when you're going to be thinking about this being chronic. There's going to be some point you have to have that decision about the fact you're starting a urine drug testing protocol. But there are other patients where you'd start at the first visit. That patient that comes here from Arizona and it's your first visit with them and they're on a long list of opioids, and that patient you don't know, you may want to test that person first visit to see, are they taking what they say they're taking? So there would be circumstances where you would start at the first visit. Whereas for most of us, starting a urine testing at the first visit may not be appropriate. So I want to get an idea from this panel on who they would start. Are there risks that we can assess that may make us test earlier, or maybe even the first time? So I'm going to ask Dr. Clark about how he uses risk assessment tools in managing a decision about whether to test or not.
Well, Bill, it's important to remember that none of these tests are perfect or foolproof, and they all are assessing essentially the same information when it comes to what types of things have you done in the past, what have you gotten into trouble with, have you used certain drugs, do you have a history of substance abuse, is there a history of substance abuse in your family? So part of these screens really involves the packaging and the format and the scoring, which is perhaps a bit more than we need to get into. But I think that you can see here that even in this short list, there are a number of different assessment tools. When you look at probably the one that is the most commonly used, the Screener and Opioid Assessment for Patients with Pain, the SOAP, that is one that has been well studied, has been looked at in comparison to other tools, as well as the clinical interview or examination by the physician or the expert. In general, that interview coupled with a screener is the best test available for assessing risk and getting to that sensitivity and specificity that we are so worried about. You have to make a distinction between really tests that are screening initial risk assessment and those that are following up patients as you monitor them while they're on chronic opioid therapy. And so, for example, there are a couple of different assessment tools that will help you with that. I think that the most important thing for the primary care physician is to know the material that these assessment tools are trying to capture, to gain a familiarity with that, and using a screen like this builds familiarity for the physician so that they become more comfortable asking about this material of the patient.
There's been some question about whether we can even do these tools, Michael, that we are limited in our time, and now you're going to make us sit down or give the questionnaire to the patient. I tell you, in my own practice, I feel fortunate when I get vital signs on my patient, let alone have them fill out some long form. But I've found, for example, the ORT, that third one you have on the list, is really very practical and easy to fill out right there in the office. You can do it with a patient sitting there, and they've shown that the interviewed form is a better, gives you better predictability on the patient. So I think there are ways to do this, and I think it's incumbent on us, the primary care doctor, to do some screening on patients.
Absolutely, and I think the important point you've just made is you've found one that you feel comfortable with and can use with the patient in a real-time conversation that facilitates the conversation and the doctor-patient relationship.
So we've given you a couple of tools that you can use, but I think we should go into a little more detail just so that you know what they look like. Michael, can you show us some of these tools and how you'd use them?
Sure, Bill. Let's look at the SOAP first. This is a 14-item self-administered form that captures the primary determinants of aberrant drug-related behaviors. It's been validated over a 6-month period in 175 chronic pain patients, and it's considered to have adequate sensitivity and selectivity. It's important to remember that, as I said earlier, it may not be representative for all patient groups, but in scoring, if you have a score of 7 or greater, you can identify over 90% of high-risk patients for the abuse of opioids. Now, in contrast is the ORT, or the opioid risk tool. You see it here in its entirety, as well as the scoring algorithm, and it's asking the same or similar types of questions, really getting at aspects of personal and family substance abuse, as well as some other psychiatric comorbidities that increase the risk of abusing opioids.
And the way I do this ORT is I have it come up on my screen in my office. I'm sitting there interviewing a patient, and I will tell the patient, you know, I'm going to ask you some silly questions, but just bear with me. I'm just trying to get through this. I wonder if you could answer these. And I'll say, is there anybody in the family that's ever had trouble with alcohol or street drugs? And then I can go down this thing. I've timed myself, less than a minute. You can get this already filled out, and you can give yourself a score. It's really easy to score. You've got it right there. Something that's really very easy to do, and you can do it in the office. So it's possible. I know you're busy. I'm busy. We can still do it. I'm going to ask Howard. Now, Howard tests everybody. Many of the pain experts does it on the first visit. But if you're going to use a rule of thumb to a primary care audience, Howard, what would you tell us to do if we're going to start initiating a urine drug testing? What would you tell us?
Urine drug tests should always be based on clinical judgment. You should be based on past behavior, past history, current behavior, and current history. However, I think urine drug tests should be indicated in the following clinical situations if you're treating chronic pain, because risk management is dynamic. Somebody who is at high risk in the beginning of you prescribing a controlled substance may become low risk, and vice versa. Somebody with low risk may become high risk. So
Howard, I think you're absolutely right, because in our practice, something tweaks us. That's that early refill, or they come in and they look drunk, they look inebriated, or you get some history from the pharmacy that they fell asleep in the middle of the waiting room. So something is tweaking us, and what you're saying is that that may be the time to start initiating, that something's going on, so that could be one of those risk categories that get you going.
You have to have some type of risk management in every time that you see the patient, whether it's just observing the patient, talking to the patient, looking at the medicine they used over the past month. Now, I think who should be tested? I think new patients who be started chronically on opioids, who are already on opioids that come into your practice should have a urine drug test. I think after making a major change in rational pharmacotherapy, you should have a urine drug test, because you want to document in the medical legal record this change. I would certainly use urine drug testing in somebody who is resistant to full evaluation. I think it's very valuable in that area. In a patient requesting a specific drug, I put a question mark about that one. Because if a new patient comes in requesting a specific drug, they're going to fall under the rubric of a new patient being tested, and therefore they're going to have it. If it's a current patient asking for a specific drug, we'll talk about why he or she wants to be rotated to that particular drug, and the pros and cons, and then make a decision, a patient-centered decision at that time. And I will use my clinical judgment whether to do a urine drug test at that time or a later time. I'll also do a urine drug test at somebody that displays aberrant behavior. And certainly a urine drug test is very important to support referral for treatment to a mental health specialist or addiction specialist. Again, a urine drug test is a test to use for the patient's benefit, and it's not punitive in nature.
I definitely concur with what Howard said. There's one point I would just like to elaborate on. The patient, when they resist full evaluation, again, I still have a problem with that. If the patient is not fully cooperative, I'm not sure the patient would need to get opioid from me as a primary care physician. If I'm a primary care physician and the patient is not willing to get the full evaluation, not willing to answer the questions, not willing to go through the evaluation, I am not sure we need to go any step further and write opioids. So again, I understand now it's overload. I'm still hesitant to overload the primary care physicians of doing all the questionnaires that they have to go to. I think compared of all the tools that they have there, I think the ORT is the most reasonable in a primary care settings. I think if they want to start initiating opioids, that could be a quick questionnaire to go through. I think point of care at that time might be reasonable, but that does not mean a confirmation urine should not be sent for this patient. This is where I think you all can tie it together and put it in. But certainly a full evaluation is mandatory. Urine drug screen specimen is mandatory. Signing the opioid agreement when it's time is mandatory. I think those are things that I do not feel that a compromise should be in play.
Well, let me make a point, and I agree with your point as far as somebody who's resisting a full evaluation. You're under no obligation to prescribe an opioid medication for chronic pain at the first visit or the 10th visit. You prescribe when you're comfortable prescribing, when you think you have enough information in your medical legal record in order to safely prescribe this medicine and follow this patient safely. So you don't have to prescribe on demand. And also you have to know if you're threatened at all, if you don't prescribe this, I will do this and do that. That's against the law. They can't do that. And that, again, dissolves the patient-doctor-patient relationship. So again, it comes back, and I agree with you, clinical judgment in each situation.
So the key points to remember are that if the patient seems too risky for you, you should refer the patient. If that referral is available, you don't have to take the responsibility to manage the patient if the risk is too high. I think, and my plea is that we, primary care, are experts at chronic disease management, and chronic pain is a chronic disease state. We can do this, but you need to have the tools. And one of the tools is assessing risk, which we just showed you how to do. So this helps you determine who you'll screen, and I want to thank our panel for being so helpful in this topic.